Yeah, very good afternoon. I'll be presenting our data on a selective endothelialectomy in a Peters anomaly. This was prospectively curated, 116 eyes of 92 children. Do not have any financial disclosure. And as we know, Peters anomaly is one of the most common developmental abnormality in a pediatric age group. Nearly accounts for 50% of all newborns born with a corneal opacity. They're mostly bilateral in 2/3 of the cases, and worldwide, this is also one of the commonest indication. Nearly all 65% of transplant being done is for a Peters anomaly. This is a unilateral. You can see a central corneal opacification. You do see a bilateral, that is significant proportion. And OCT distinctly mark where you have a defect. You can see, rest of the anterior lamellus, although Bowman's membrane is, it is fragmented, the rest of the corneal contour seems to be relatively preserved. Again, to show you UBM, where you have a keratoirido lenticular, or sometimes iris is failed to separate, or sometimes lens is failed to separate in a severe form. Although, there are publications which actually shows a good outcome long term, but if you look at, child's life expectancy at the time of surgery, let's assume 90 years. As against, post-cataract surgery in any adult, you have a 20-year life expectancy. So in the long run, you end up having a abysmal outcome. Therefore, we need a very alternative procedure which is very simple, easy, and anybody can do such a procedure. So that was a question we had when we started this journey about 10 years ago. Through our retrospective papers, we've already shown efficacy of this particular procedure, and it is 97% of the cases had a clear cornea. And for calculation's sake, I've included only 78 eyes of 62 children which have completed at least 6 months of follow-up, although we've included all cases to show whether any complications or side effects. We have to reclassify and categorize into mild, moderate, and severe based on the zone and the site of involvement. For audience, I just want to show this particular video. You can see a very distinct central opacity. You have a pigments that actually demarcates the perimeter of the corneal opacity. It's a pretty simple, easy surgery. Any pediatric or anterior segment surgeon can easily do. And all I'm doing is just polishing and removing that anomalous layer. And if there are any synechias, we also sever that. And care has been taken here not to disturb the Descemet's membrane. And also, if you carefully look at the video, I'm removing these cells, connecting, bridging, if any bridge between the healthy cornea and diseased cornea, that also serve as a contact inhibition. So I'm collecting these cells, and we are actually doing a single transcriptomics on these cells. Need to know why they are immature. So that's it. It's a very simple, easy surgery done under a good retro illumination. And serially, if you look at, this is the outcome. The same child after 4 years, you can see right and left eye has a significant clearing. You can see in a pre and a post-op outcome as well. And same has been documented on a OCT. Although, it is a surrogate measure, it doesn't show there is an endothelialization by 30th day. But you have a new Descemet's membrane which is sharply demarcated, and cornea is much thinner compared to what we started preoperatively. And same has been expanded to a variety of cases. You have here a partial clearing, complete clearing, partial clearing, and all these outcomes were evaluated by the photography by 5 different masked observers, and they made a mark, it is cleared, partly cleared, or non-cleared. We also have a OCT for all these cases to demonstrate there is in fact endothelialization. And those which had only a mild disease had a SEPA, which had more than 7 millimeter opacity, were also combined optical iridectomy, because I have a concern about amblyopia. And those which had a lens attachment, I've also removed the lensectomy in addition to the CPAP. If you look at mild disease, they tend to clear much quicker. Nearly 75% of them had a complete clearing, whereas about 24% had a partial If you go in the slide with the spectrum, with the severe spectrum, your efficiency actually comes down. Meaning, for a mild to moderate disease, it works extremely well. So is the visual functions. Our data actually shows, based on last 10-year data, it works very well in a select case of Peter's anomaly. Possibly, it may be a superior surgical alternative which circumvent all complications related with the conventional penetrating keratoplasty. These are my references. Thank you.
Thank you, Murli.
What about the post-operative medication?
Yeah, great question, ma'am. Only 4 weeks of topical steroid. Generally start with 4 times, tapered over the 4 weeks, and just add antibiotic for a week's time. And at the end of second or the third week, based on the age of the child, if child is an infant, I would remove the suture within 2 weeks. If it is a little older child, so I would remove time between 3 to 4 weeks. And all of them need a spectacle correction. Those which had a CPAL, they have eye hyperopia, an average 14 diopter.
Also, was there any analysis of the time of intervention? How soon after birth or after detection?
Excellent, ma'am. I think younger children tend to do much better. If you have a bilateral disease, they present within a 3 months window period, where I believe peripheral endothelium do retain some amount of mitotic potential. They tend to clear much faster, and average duration to clear the cornea is about 4 weeks if the opacity is less than 7 millimeter. If the opacity is more than 8, it will take almost 3 months for a clearing.
And you took 2 sutures at both the entry points? Just single sutures of tenonylon?
Correct.
Okay. And what is your explanation for this success? Are the cells gliding over from the unaffected areas?
Correct, sir.
And filling up the defect?
Correct.
And there is a laying down of new decimes?
Yes, sir.
Which is healthier?
Correct.
Okay.
So the reason is, the central anomalous cells, they serve as a contact inhibition. Normally, I'm sure we all observe Peter's anomaly tend to regresses with the time, but it is not that, robust. So you're only facilitating the normal healing process. If you ask me any limitation, I think it is all single surgeon experience. Although I've been receiving reports from, worldwide people, every day I get an email, but we have not tested. Can it be replicated in others' hand? Because, it has a stringent inclusion criteria to, include. That's only limitation what we have.
All of us have inadvertently experienced this when we've torn or ripped the decimes while doing surgery. And sometimes the patients have been lost to follow up and come back unexpectedly with good vision.
Absolutely.
Yeah.
Thank you.
Thank you.